Evening, one and all. At the outset, I would like to thank Dr. Kumaravel sir and the Alpha Hospital team and the chairpersons for the introductions. And I will be focusing regarding the adrenal insufficiency, when to suspect. And so these are my overviews and clinical, biochemical and imaging, and how to approach etiological diagnosis and confirmations, and a couple of slides regarding the management. And this is a anatomy of adrenal gland. So you can there are three layers. The broad one is a cortex and medulla, and glomerulosa, fasciculata and reticularis. So it secretes various hormones from aldosterons, cortisol and adrenal androgens and stress hormones. So there are the tight relationship between the hypothalamic pituitary adrenal axis as well as the aldosterone secretions. So the both are closely related whenever the adrenal insufficiency has to happen, and when more than 90% of the adrenal is destroyed, then commonly it may manifest as adrenal insufficiency. And so there are a lot of stress hormones, basically the adrenal hormones, and predominantly there may be a metanephrines, but in addition the cortisol also is one of the stress hormones. So there is having important relations in critical illness also, this adequate of hormones. And simultaneously there should be a balance between aldosterone regulations also when adrenal insufficiency is there. And what are the ways the adrenal insufficiency can present? So predominantly they present to the general physicians or general practitioners, and at last it may come to the endocrinological part. So the most common presentations in current situations may be the gastrointestinal symptoms, and most of the times the gastroenterologist, they may be ruled out from their part. And at last nowadays the increasing awareness also is there, and people are using more of alternative medicine. So they may not have very classical symptoms of adrenal insufficiency except this nausea, vomiting. So any weight loss of significant weight loss then always has to suspect, in addition to the malignancy, tuberculosis or other indications and hyperthyroidisms. So the predominant gastrointestinal manifestations may be a nausea, vomiting, and provided in non-diabetic individuals. Hope they are not taking metformin or any acarbose or oglibose. So after ruling out all the things, one has to keep it in mind that adrenal insufficiency, one of the common symptoms of adrenal insufficiency is nausea, vomiting and diarrhea. And so one should not forget to ask regarding the alternative medicine use, and commonly the lot of preparations are there, and some of the things they can cause hypokalemia like adimaduram, and some of the things predominantly they also contain some steroids, and unfortunately we don't do the content of that alternative medicine. And other manifestations are dermatological symptoms like hyperpigmentations and stria. So the classical these type of strias will be seen predominantly in exogenous Cushing's or glucocorticoid induced adrenal insufficiency. That was the recent terms being used for instead of exogenous Cushing's. So the classical stria, one more commonly associated with exogenous rather than the endogenous because of this. And at these junctures I wish to inform that these are the various steroid preparations and the hypothalamic pituitary adrenal axis suppressions. And you can see that over the counter usage of drugs is very, very common in India, and in commonly now we come across the Setumatrai. So this that contains predominantly the dexamethasone. And what is the major notorious things about dexamethasone is it is the most high hypothalamic pituitary adrenal axis suppressions as comparing with other steroid preparations, and similarly the fludrocortisone also. So whenever this much amount of potent steroid whenever you are using, the axis suppression is very, very severe, and the recovery also will take very long term, sometimes maybe months together or years together. So the degree of steroid usage, it shows about the longitudinal continuation of the adrenal insufficiency. So we have to, the history taking is very, very important whenever you are using or we are diagnosing adrenal insufficiency. and fludrocortisone also, and methylprednisolone also. So whenever you are using short course of steroid for the purpose particular indications, it doesn't have any harm, whereas long term definitely it has having negative impact. And autonomic symptoms like postural hypotensions or giddiness, or there may be a features, and other non-specific like EC fatigue, tiredness and weakness. And so the summary of when to suspect adrenal insufficiency, so it is a very broad symptoms and broad specialist they may go to, and the gastrointestinal symptoms may be more common in addition to the weakness, nausea, vomiting and joint pains. And one should not forget about hyperpigmentations and other thing. Why hyperpigmentations? Because of the, as already told, that the negative feedback. Whenever the cortisol is low, it starts secreting more and more ACTH. So the ACTH acting in the melanocyte stimulating hormones on the skin, and hyperpigmentations. So hyperpigmentation is one of the very important diagnostic clue to suspect Addison's disease. And what are the signs? And you can see that the friction area predominantly, and maybe the sole and palmar crease, and there may be in axilla, and so there is a hyperpigmentations, and you can see that the vitiligo. So the vitiligo is a marker of autoimmunity, and hyperpigmentations alternating with vitiligo, then definitely there is a chances of autoimmune process is going on. And rarely there may be auricular calcifications. And this is one of the data, it is a retrospective data from our Madurai Medical College, and predominantly in a decade back, whenever patients, any patient say of middle age group comes to you, then it is definitely most commonly tuberculosis. That was the dictum, and but not so in nowadays. And the most common cause of Addison's disease is autoimmune causes rather than the tuberculosis, and like similar to the hypothyroidism. So we are moved from the iodine deficiency to autoimmune hypothyroidism. So similarly here also tuberculosis we have very good now diagnostic part and almost treatment. Even if at all tuberculosis causing adrenal insufficiency is rarely or likely more due to the MDR TB rather than the classical TB. So tuberculosis Addison's is very less common in nowadays. So any Addison's if you are suspecting, you always curious to assess the etiological of Addison's disease. And autoimmune, unfortunately we don't have very good robust diagnostic test, and PGA, polygonal syndrome type 1 and type 2, APLA syndromes. So any adrenal hemorrhage or any DVT in a male, be on vigilant follow-up. APLA syndrome is one of the antiphospholipid antibody syndrome. Female, they may be more commonly been recognized because of the recurrent pregnancy loss, whereas in male, DVT without any other risk and hyperpigmentations always rule out the APLA syndromes. Adrenal meds is a rare causes, and you can see that there is a two autoimmune endocrine syndromes, polygonal syndrome type 1 and type 2. So type 2 is more common. So any Addison disease with other coexisting endocrine associations, it is a polygonal autoimmune syndromes. And in type 2 there is a thyroid, and there may be a type 1, whereas the type 1 is it is quite rare, and the other two important things are hypoparathyroidism. Patients may present with hypocalcemic tetany, and there may be a alopecia areata and pernicious anemia and other rheumatological manifestations. So by summarizing the etiology, the sporadic one and polygonal syndromes and infections. So among the infections, it is nowadays becoming less in tuberculosis. So always any bilateral adrenal mass, you should rule out adrenal insufficiency, and any PET scan incidentally picked up by other these things, bilateral adrenal mass. So bilateral adrenal mass predominantly either infections or metastasis. That is the two important reasons for primary adrenal insufficiency with the bilateral adrenal mass. And childhood causes, I am not going into the detail. And as already told that the most common adrenal insufficiency is secondary or central causes or glucocorticoid related. And so the exogenous steroid therapy is one of the most important things. And Sheehan syndromes also, it is one of the things. So the Sheehan syndromes, very easy to pick up. Lactational failure, any women with lactational failure and secondary amenorrhea following the delivery, and usually the adrenal insufficiency will manifest after 10 years. It is not immediately, and so it is one of the cause. Still we are getting because of the some postpartum hemorrhage or peripartum hemorrhage and vascular insult. So even though the obstetrics care has improved, but still Sheehan may be there. So there may be some autoimmune causes again in the antipituitary level. And so these are the reasons for secondary adrenal insufficiency. And by simple electrolyte estimations also we can predict or we can suspect. So one is a hyponatremia with hyperkalemia. So it is a late stage, but still for routine investigations or for any hyponatremia with hyperkalemia, always suspect primary adrenal insufficiency, and any hypoglycemia of classical phenotypes, again suspect adrenal insufficiency. And secondary and tertiary, there will be electrolytes may be a normal. And here after the imaging, you can see that this is the bilateral adrenal calcifications, and there may be a rare entity called primary adrenal involvement by tuberculosis, but whether lungs and other thing will be normal. So that is one of the rare quiet cause, and this bilateral adrenal calcifications is as a result of sequelae of any previous infections, fungal as well as the tuberculosis. And bilateral adrenal mass, so this is the kidney, so above the kidney there is adrenal, and here one of the hemorrhage, the hyperintense lesions in the left adrenal. So there is a Apla syndrome is one of the things most commonly associated with adrenal insufficiency, and so these are the various etiology. And coming to the natural history, similar to the diabetes, the Addison's disease also is having natural history. So any genetically predisposed individuals, whenever there is a triggering factors, and there is with the background of more and more antibody synthesis, that is anti-adrenal antibodies, and it destroys the adrenal. So the autoimmune, again one of the more common etiology. And quite interestingly that ACTH will start elevated in the stage 3 and very high will be stage 4. So one has high index of suspicions rather than to have the very, very high ACTH that happens at very late stage of disease. And this slide shows the circadian and pulsatile secretions of ACTH. So whenever you are doing any cortisol estimations for the Addison's disease or any Cushing's or cortisol excess, there is a circadian rhythm and pulsatile secretions, and you can see that the ACTH pulses is very high at the early morning around 4 o'clock and around 6 o'clock. So the cortisol also has to be estimated at particular point of this time because of the circadian and pulsatile secretions, and but it may be altered in case of poor sleep or shift worker or night travel. So whenever you are interpreting any cortisol, it has to be keep it in mind that the circadian rhythms, and it is one of the endocrine hormones, it has to be maintained throughout the things. And how to confirm in borderline cases? So this is one of the test, ACTH stimulation test, otherwise known as a short synactin test, and commonly it is available is a actin prolongatum. So this is common used by blepharospasm and other neurological neurologists also using these drugs, and it is one of the animal sources of ACTH. Otherwise synthetic ACTH also infrequently may be available in India. And so in borderline cases you give these injections and you do the 1 hour, that is 60 minutes of cortisol estimations. And one thing I want to highlight here is ACTH to be collected, sample to be collected in EDTA tube, and many of the labs, if whenever we are asking or requesting ACTH, it has to be in well standardized lab, otherwise the report may be equivocal or it is difficult to interpret. So ACTH one of the very, very rare tests in endocrinology, and it has to be done with the special precautions, timing, and the EDTA and plasma samples rather than the serum for other cortisol estimations. So whenever the 8 AM cortisol, if circadian rhythm is maintaining, always preferable to do at 8 AM or 7 AM cortisol. When patient came to emergency with very sick conditions, you do random sampling and don't wait for the investigations, and you can start the steroids. So before giving any hydrocortisones, or you can do 1 or 2 doses of dexamethasone, it doesn't interfere with the assay. Otherwise, adrenal crisis, if you suspecting, you take the sample and you give. After sampling or after giving, you are taking sample, then the report will be erroneous and it will be very difficult to interpret. So whenever less than 3, then it is sure that it is likely adrenal insufficiency. And whenever 3 to 15, that is a unit is microgram per deciliter, again it is equivocal, more than 15 it is normal. And in very sick conditions, it may be more than 20 or 30, 40 also can happen. It shows that adequate adrenal reserves are there. So then you can do the ACTH estimations, and ACTH will be elevated quite long time. So ACTH also is one of the wonderful clue whether it is really Addison's disease or not Addison disease. And so the symptoms and signs of adrenal insufficiency are you do the appropriate lab test and imaging if it is needed. And nowadays, recently the adrenal antibodies are becoming commercially available, but it is ELISA methodology. And otherwise, autoimmune adrenal, we cannot able to surely confirm it. But the other autoimmune markers like anti-TPO antibody or parietal cell antibody in pernicious anemia. So some of the other autoimmune disease markers may be a coexisting clue to suspect autoimmune etiology. Otherwise, if Addison's suspected, then definitely you have to rule out lung CT or adrenal imaging. Both are needed to identify the etiological diagnosis, because once diagnosed, the lifelong steroid therapy is warranted for that individual. And again, we have to emphasize about stress doses of steroids and double the doses of steroids. And if it is skipping, then again they have to get admitted, and that all the things also need to be informed. And coming to the last one, the adrenal crisis management. So as already told that any clinical suspicions, you take the sample and give the steroids. So the simple effective thing is hydrocortisone, and then IV fluids for the hypotension corrections. And then after the bolus dose, you can start with the 8th hourly or 6th hourly. And infusion is better. If it is facilities are available, then hydrocortisone infusion may be a better rather than the peak and troughs may be avoided. And once acute critical conditions is over, then you can switch over into the maintenance dose. So the safer steroids is hydrocortisone, but in adult, we can go for the prednisolone. That is no harm, but physiological dose may be 5 to 7.5 milligram per day. So not to increase beyond this one, and unless morbidly obese is there. So the prednisolone of 5 milligram is good enough. It is equivalent to the 20 milligram of hydrocortisones. If needed, maybe 2.5 milligram of excess you can do. And biochemical things, you want to assess renin and aldosterone 1. But again, it is a costly investigations as comparing with the other modalities. And definitely fludrocortisone is one of the things has to be there in the prescription of primary Addison disease, primary adrenal insufficiency or Addison disease. Fludrocortisone is not required for secondary adrenal insufficiency or central causes of adrenal insufficiency suspected. And recently this DHEA also available, that is a adrenal androgens, and commercially these preparations also is available. It improves the libido and some of the rare psychological disturbances by this DHEA's assessment. And whenever using a chronic steroids, and if the critical period is 3 weeks, any steroid of 3 weeks, less than 3 weeks of if your usage, then in another minute I will be. If less than 1 minute, less than 3 weeks, then you can stop it abruptly. If any steroid of more than 3 weeks duration if you are using, then always better to taper and either convert into prednisolone or hydrocortisones. Then it will be easy to, so the tapering needed whenever the duration of steroids of more than 3 weeks. Otherwise, short course of steroid of 1 week, you can abruptly stop it. And so the adrenal insufficiency is a systemic disease and may present to the various specialists. And the clinical suspicious is very, very important. And tuberculosis is no longer the leading cause of Addison's disease because of the improved various parameters. And primary adrenal insufficiency individuals require lifelong surveillance for possible development of coexisting autoimmune syndromes. So they may develop thyroid disease in later hyperthyroidisms, and in such individuals yearly pregnancy also to be advised because they go for hypogonadisms and premature adrenal insufficiency. And autoimmune is increasingly being recognized as a cause of Addison's disease. With that I am concluding. Thanks for the kind attention.
Thank you, sir.